Innovations in the menopausal care market is our episode topic. My guest is Bryan Cote, a managing director in BRG's Healthcare Transactions and Strategy Group and author of a September 2024 white paper titled The Menopausal Care Market, which is available on the BRG website. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Bryan, thank you so much for joining us today.
Great to be here.
Before we get in our episode topic today, can you tell us a little bit about yourself?
I live in Connecticut. I've been a healthcare researcher and writer for about 25 years. Family of 6, 4 kids, youngest 18. I started as a journalist in the mid-90s. Basically consider myself still one. I was a reporter for about 15 years. My roots were community newspapers, and I still write a column every day. Then I started being, around 1998, called the Behavioral Health Hour, a column that was in Herald, which is a newspaper up in Boston for those from New England. And one of my first columns I remember was about my great aunt Mary, who was a nurse who I always considered like a Scrooge around the holidays, which doesn't fit how we think about nurses necessarily. But she worked at Mercy Hospital in Springfield. And my columns are often like just about the behavior of people and people in my family. I often wrote about that. And I remember her as like a tough one. But I remember visiting her around Christmas when I was volunteering at that hospital. And she didn't like the gifts or anything like that. And I found her up in a room with a patient playing like a hand of gin rummy, probably cheating, but holding that patient's hand. And my roots are like in storytelling and writing and journalism. And I tried to take that through that column I've written for now 20 some years into healthcare research. A lot of the readers I've collected through the journal I do over the last 2 decades are those in healthcare, hospitals, insurance companies, physician groups, schools and educators and consumers. So in our work at BRG, I'm a managing director here, one of them. We often have to do quick research into what the community thinks about, let's say, a new technology or drug, or which way the wind is going to blow for a specific healthcare business. So having access to all those people I've talked to over the years and done stories on, not just my great aunt Mary, but many others, has been really important.
You recently published an article with BRG titled The Menopausal Care Market, and would love to hear more about that and its impact on ability for care on patients and also care strategies. So what was the impetus behind this article?
Probably twofold. We do a lot of polling in our group of consumers, women, families, really on an ongoing basis to figure out where their heads are at around their own healthcare and healthcare issues. And you could see it over the last decade plus for women who are in their 30s, 40s, 50s, really struggling with like that sandwich generation issue of I'm trying to manage my older relatives, my parents who are getting sick, my younger kids who are dealing with growing up in the era of social media, and my own healthcare. And I'm not really paying attention to it. And I'm struggling to get time with the doctor. I'm struggling to understand why I'm gaining weight, struggling with anxiety, all of that. And then from that research, we're talking thousands of women who reported back to us frustration with the healthcare system. And a lot of it was that period, that basically 15-year period of menopause, pre-menopause, and then during menopause. The problem is most of the healthcare insurance market and the employers and the physicians have struggled to really figure out a good way both to do really good diagnostics and treatment and coordination for that population who really need support. And I think it's been one of these like underappreciated episodes of care. It's really long. It's not pregnancy. It's not like the 9-month thing. It's not surgery. Gets a lot of attention. And it's not like the hot button things like pregnancy, maternity, and fertility, which are big issues, even political issues, obviously, in the country right now. And we started to notice it and figure, wait a minute, we need to zero in on, is there a solution to help women and families with dealing with menopause in a more effective way? Because the health conditions, Nick, that can come from this are massive. You're talking dementia, heart disease, Alzheimer's, mental health issues that, if not addressed, can get really bad during that period. And it's clear there's some companies now that are trying to say, hey, we're menopause specialists and we can help serve women and families. So we thought we'd write a report to at least raise awareness about it.
And what does that mean? What does it mean to be a menopause specialist? What kind of services are these providers offering?
Good question. Largely, the number of menopausal specialists per women in the country is pretty small. Like we're talking undersupply. I think the stat we had was in the report, one specialist focused on menopause, educated in menopause diagnostics and treatment for every 35,000 women. Not a great stat. Like I think pediatric dentistry is a good example of one that doesn't have, it has a supply imbalance. Mental health's another one that's been flagged. To be a specialist, you could be an OB-GYN, an OB or a gynecologist. That could be the route of your training. A lot of physicians have left their practice frustrated with call. I got to do call in the hospital. I'm struggling with the economics. I'm at an age where I'm really not managing patients like I thought. So I'm going to leave and I'm going to get training on hormone replacement therapy, testing of women, really understanding how to figure out if you're in menopause or not, and then manage the women through that period and not be confined by the boogeyman in the room is insurance only lets me do a certain amount, right? It's a certain length of visit. I can only get paid a certain amount. It can't really solve the problem. So I think what a lot of the OB-GYNs frustrated with health insurance, frustrated with the lack of time they can have with patients, have left practice. Let's say you get a group practice of 5, 6 OB gynecologists, you get one of every 5 start to leave and hang a shingle. And that was the roots of the menopausal specialist companies, doctors who said, I think there's a better way. And those are cash pay businesses though, right? That's not typically available to someone who's on Medicaid. Very rarely will commercial insurance, 5 years ago, accept payment for this. Starting to change where you're starting to see the big health insurers and employers like a self-insured employer say, look, a lot of our population are workers or members in that 35 to 55 year range. We need their health well managed. Maybe we'll put one of these businesses into our networks and pay them to manage care and lower costs. What I haven't seen yet, but I believe it's starting to happen, is more participation of nurses, APRNs, NPs, not just as part of these groups. A lot of times these menopausal specialist groups are solo practices. That's how it forms. And I think the NPs and APRNs either join it or I've heard they start it themselves. They form a group. Because if you think about nursing, right, you can be a nurse in so many different levels of care, hospital on down to home. And COVID really affected where nurses practice, how they practice, the challenges that they face, particularly those in skilled nursing facilities. And it's a real opportunity for nurses to get more education on hormone replacement therapy, menopause as a condition. The story I'll say is my neighbor was in a skilled nursing facility, and that was tough during COVID, seeing all the families that had to struggle with that loss and herself having to deal with the illness and all the challenges that occurred. She went through some training and has started a kind of practice with a few others, including an OB-GYN, to help deal with women in menopause because she saw how it affected her own mom, right? Who got dementia at an early age and starts to see, all right, I think there's a tie here. If we mismanage it, it can go down a road of having these unmet health conditions.
What changes in the payer market are you seeing recently within the last 6 months to year around the menopausal market? Is there starting to be some payment for it? Do you anticipate that in the future?
It's slow. The health insurers are publicly, there's a lot of talk about, look, we want to embrace women's health. We only really recently, as 2018, started with bundled payment and value-based payment for a really successful pregnancy to deal with not just like a successful preterm labor process and surgery, but obviously post-term or postpartum depression. And they spent all their time around primary care and orthopedic bundles and shared savings. I think that the Medicare Advantage plans, which are also essentially owned by the same entities that have the commercial plans, are starting to realize that they have members for a longer period of time than they used to be. Like if you're a commercial insurer, you might have that family or personally for a year or two. And so you never really were incented, right or wrong, to pay providers for really good primary care and managing downstream costs and doing testing. And I think that is beginning to change. I think the self-insured employer market is starting to see some value in recruitment and retention. And they're going out to some of the businesses that call themselves menopausal specialty companies saying, we'll pay you a case rate of say several $100s a month to manage this individual who clearly who is in early menopause so that they can get more structured, specific care outside of just the traditional primary care visit. That kind of investment by bigger companies, think like a Disney or those kind of entities that are self-insured and have a big female population, they're thinking retention, recruitment, good care, and I'm going to have that individual for years and years. I think the big payers, Aetna, Cigna, United Healthcare, and the Blue Cross and Anthem plans are just starting to pay attention to this a little bit. I think they'll be slow to adopt it. They'll put these companies in their network. They'll start to offer benefits to women, like you can get in with one of these specialists and we'll cover most of that care and we'll pay them like a fee for service kind of payment. I think the question, I've talked to physicians who are medical directors that work for the health plans. They say, what we'd worry about is further fragmenting the care. So you have, it's almost, I guess the analogy could be like a freestanding ER facility where someone might go for a chest pain. Is that really the right thing? Because they eventually might need to go to the hospital. Are we creating this Band-Aid and where the patient isn't educated on where to go? I think the medical directors inside of big health plans are saying, all right, you have an OB-GYN here, you have a primary care doc here. And then on the side, you're seeing this specialist. Are you all really connected? Are you all talking? Are you all operating on the same protocol? Probably not. So one might disagree with hormone replacement therapy. One might like it. I think there's some skepticism about that because it's not a medical home. It becomes like care all over the place. But if you're a woman in a family and you're struggling and you're feeling like I have all these symptoms and you're not managing them, I have 15 minutes with you in an office. So I think we have a long way to go in terms of like payment policy, catching up with the innovation in the market that's starting to form, like these like models and the clear frustration of women. Like my wife is in her 50s like me, and this is a tough time to raise younger kids, take care of our older folks, take care of our own health. Hopefully the insurance industry catches up. We'll see.
Yeah. So you're talking about the providers basically having their own shingle or their own independent entity. Are you seeing any menopausal care specialists nestled within existing women's health practices, OB-GYN practices, where you've got a doc that's been practicing in the practice for a number of years, and rather than close up shop, so to speak, they just shift the nature of their practice within the larger OB-GYN practice, so to speak? Is that happening also, or is it truly they're out independent on their own?
Independent.
Okay.
I got to believe that is going to be an area. If an OB-GYN or a women's health company, and some have come to us, some of it is really through the space of trying to expand their company into different markets, different states, trying to get better reimbursement rates for the care they do. One way to get the attention of Centene, a Medicaid health plan, or Blue Cross Blue Shield is to say, look, we have 2 menopausal care specialists and we've trained the NPs on that. And so when someone comes in, we don't just say like, when was your last period? Which is a question every woman gets. I'm told by my wife and others, but yeah, like they don't really do anything with that. It just ends up in the documentation. What if I were an OB-GYN practice and we suggested some should do this, carve out a niche or a program and your protocol and how you like identified early menopause. And if when someone's in it, you set up specific appointments for them. Maybe it's virtual. But a lot of the companies that are, their own in this space, The names are all like, they blur together for me. I think there's one called Alloy and Evernow and Electra. Those are ones that come to mind. They're basically poaching OB-GYNs and NPs from a lot of these practices. So like, why not, if you're a women's health company, create your own sub-service? I don't think they're yet incented to do it by the employers. And they're just like trying to just keep up with the demand. I don't think it's a big trend yet. If it becomes one, that would be really good for, obviously, for families, and probably a better model, Nick, right? Is they're integrated.
So, if I'm thinking right now for our listening audience, which is mostly chief nursing officers and those that are aspiring to be in those roles, I'm probably thinking about it from two perspectives. One is the patient care population that we care for in the health system or within the hospital itself, and thinking out, okay, is there an ambulatory strategy play here that we can do to keep patients out of the hospital by getting them into these menopausal specialists, and what does that look like? How do we have an ambulatory care strategy? But the second is knowing that, hey, a lot of my workforce as well are women, and what do we do for our own employees to get them the care and the access that they need so that we can keep them healthy, so that we can keep them employed and keep them working and providing great care in the organization in which we're operating? What would your thoughts or advice be for those individuals that are serving and working in those roles of how we can take this information at play and apply it to our practice?
It probably would be, it's a great question. It would probably start at the board or C-suite level to say, look, we need to train. First of all, we need to make sure we're training our residents in this field. You do your rotations, or eventually you're obviously in a residency, or maybe the med school, it maybe should start. And then you train at the residency level on better training rather around menopause. You might even create some specific tracks around that, or both for the physicians, but those also going through nursing school, and create maybe programs where you have those through that training, working with an OB-GYN in the health system, academic setting, seeing patients who've been identified. So you start to develop some protocols and outcomes around it. But I think at the highest level of the health system, they have to invest in identifying that's an issue for their own employees and their community. Two might be better protocols on how you get into the data when someone's coming into ER and or coming in through the health system, just through the primary care or OB-GYN practices for their checkups, and like how to better parse through and identify indicators of, let's say, early menopause, and train whomever, clinicians, non-clinicians. I suppose we can use some sort of artificial intelligence to target, okay, these 5 things are happening. That should trigger a phone call and a meeting and some education. If I'm a health system, either I create a program for my own employees around this and offer that as a benefit if you're in that age group, because a healthier employee, as you are saying, it helps our own entity. And as a business strategy, you should either have 5 or 6 specialists in the market that you can refer patients to, or you acquire one, or you build one of your own. There's certainly a lot of reliance on the OB-GYNs to do call, perhaps developing a women's health partnership that's dedicated just to menopause would go a long way. And I think it would probably help with pushback on the health insurers, who are certainly giving hospitals a hard time these days. It might be a way to create more synergy. You're getting care in the hospital and you're reducing a lot of unnecessary admissions.
You talked earlier about how this innovation or innovative practice really has started to emerge. One, there was a consumer need, and two, there was also on the provider side a need of desire to transition practice and finding a niche where people can meet. Clearly, you've laid out the opportunity for some improved outcomes. Is there any evidence out there right now that this model does generate truly better outcomes at a lower cost?
I think it's out there, but in pieces. It's a wide net in age. You're talking potentially in your 30s, potentially up into your 60s. You made a really good point that at a population health level in a given market, the major employers might be hospitals, and they often are. I have not seen a really good longitudinal study. If I'm using the right, I do research, but I'm a journalist by trade. I love research, but I'm not a scientific in that. I haven't seen one that's measuring or monitoring or following someone over multiple years. I think a lot of the evidence around the outcomes of savings to early diagnosis of things like dementia or earlier identification of issues around heart disease, which is obviously like number one or number two in terms of
Yeah.
mortality, morbidity for women. Yeah, I suspect that the data is there. Someone needs to make that a priority. I've noticed Cigna, which is an interesting business in that their big emphasis in the last 2 years, they're not the only ones as insurers, is around behavioral health and mental health, which is one of the major symptoms, anxiety, that is often just dismissed, though now it's still treated. It's not often thought about in the context of, oh, you're in early menopause or you're in menopause, and we need to look at a lot of things. They're starting to publicly talk about menopause and hot flashes and the risk of heart disease and dementia and Alzheimer's in ways like I've not seen before. So the data has to be there, but you're talking about all kinds of medical issues and mental health issues. So how to someone needs to figure out a way to piece all of this together in a way to study the effect of, let's just say, a year of visits with a specialist, lifestyle changes, diet and exercise, but also the role of hormone replacement therapy in making a real impact on the health of someone in menopause, or some of there's some non-pharmaceutical interventions for things like hot flashes. It's almost like you have to study. I say the market needs to study, and maybe that could be like an academic with a menopausal specialist company following a cohort for 5 years. I don't think there's been a lot around that yet.
Any closing thoughts as we wrap up this episode?
The menopausal care market is still very much forming. If I am a nurse executive, a chief nursing officer, or just an NP, APRN looking to better manage the care of my patients, there's probably a real opportunity and under cost to poor menopausal care, which is a shame it hasn't been talked about yet. And it could be one of the real business opportunities, I think, for health systems and payers and providers going forward. But I think a lot needs to change in terms of how we train and educate the market over the next 5 to 10 years.
The Menopausal Care Market has been our episode topic. Bryan Cote from BRG's Healthcare Transactions and Strategy, thank you so much for joining us today. The paper that we've talked about is available as a link in our description for the podcast episode. You can also download it off the BRG website. Bryan, thank you so much. Appreciate your time.
Thank you.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.